Welcome everybody back to the podcast. It's so great that you can come and join us. My name is James Waldron, GPnotebook podcaster and educator, and I'm really glad to be joined by a special guest today, Rik Fijten, who is a GP partner, a Hepatitis C GP Champion in Bexley, and he's joining us today as part of this three-part series on hepatology, Hep C and Hep B. Welcome, Rik.
Uh, Thank you, James. Thanks so much for having me today. Really pleased to be here.
Oh, wonderful. And got so much knowledge to share with us. And in fact, I understand you've just started a role, an evolving role in gastroenterology in secondary care as a GP. First, let's start off with that. Tell us a little bit more about GP's impact in this space.
Yeah, absolutely. It's a role that I'm really excited to be doing. It's a framework and program developed by a GP in Bath called Dr. Charlie Andrews, alongside the Primary Care Society of Gastroenterology. And they have developed this framework to allow GPs to develop an extended role in gastroenterology um, through doing a clinic for one session a week with half a session educational time. So it upskills us as GPs to work across the primary secondary care interface, carrying out research, working on advice and guidance, improving pathways, and doing other things such as endoscopy. So really fantastic program, and hopefully will inspire a lot of other GPs to take an interest in this space.
Well, that's wonderful to hear. I mean, as we're going to be talking about today, this is very much a primary care thing, hepatology and liver disease. So I think us taking an active part in that and being able to explore things that really make a difference and are meaningful for us. I understand you've been part of the Primary Care Gastroenterology Society for a good length of time. Being able to empower us, I think it's an amazing thing to do.
Yeah, it's a fantastic, and I think most GPs or a lot of GPs are looking for variety in their working week. Um, and there are some specialties that have this type of program established already, but I think we need more of this, to get retain GPs and keep them interested in primary care. There's definitely something that I'm really looking forward to doing.
Wonderful. Variety is indeed the spice of life. So why talk liver disease?
Of course. So, I think thinking about today's podcast and hepatology specifically, um, we know that over the last 5 to 10 years, the prevalence of liver disease, specifically um, uh, metabolic dysfunction-associated steatotic liver disease, so a bit of a mouthful, but formerly fatty liver disease, the prevalence of this condition has been increasing quite significantly, and the all-cause mortality associated with it has been on the increase, whereas other chronic health conditions, such as cardiovascular disease, we've seen improvements in outcomes. And that's not been the case with liver disease. Um, it's it's extremely common. So it's estimated that about a third of the UK population have MASLD, as it's termed,
Yeah.
and
So MASLD being, I suppose, the newer name for what we used to call NAFLDs, isn't it? So it's the
absolutely, yeah. So and it's felt to be a more appropriate term because I think we'll touch on later is that it's very closely linked to metabolic dysfunction, insulin resistance, and diabetes specifically. So um, I think it's given how common it is, and given how many patients we see in primary care day to day, and the chronic disease management that we carry out, it's so important that we as GPs, and not just GPs, that the primary care workforce as a whole, are thinking about this condition, um, and are confident in spotting it and managing these patients.
Yeah. I mean, and certainly if we're talking about 30% of the adult population, we're seeing it all the time, whether we recognize it or not. And I wonder whether one of the challenges of getting people really interested in this, or to take it more seriously, is that it's often silent. We don't. People don't come and say, "Oh, I'm worried about my liver," generally, but they might say, "I'm getting chest pain." So I suppose it's up to us, isn't it, to think about it.
Yeah, absolutely. So I think that is, as you said, is the big challenge with liver disease specifically. Um, Patients won't have symptoms. It's We have to go looking for it. So when we're thinking about, you know, those chronic disease reviews, specifically diabetic reviews, hypertension reviews, um, we need to have it at the forefront of our minds. Weight management as well. We know that the prevalence of people living with obesity is rising, and we really need to have it as part of our assessment when we see these
Mm.
patients.
So I guess that takes a bit of a mindset change for what we're doing. We tend to be quite reactive and respond when people come in with symptoms. But again, when we're talking about the long-term plan and prevention rather than cure, one can't talk about this without thinking about liver disease because of the potential benefit we can add here, but also the potential risk of not doing anything about it.
Yeah, absolutely. So we know that if we can identify patients with um, this condition is reversible with the right support. Um, and of course, access to that support, as we know, is challenging currently. Thinking about your weight management support, um, and specific dietary support and physical activity, which we know can all improve this condition. We know that's challenging, but we are in a position to have that conversation with a patient. Um, and I think in a lot of cases that does really have a significant impact on outcome and trajectory of that patient's journey. As you said, if we know that a proportion of patients with this condition will go on to develop what we call metabolic associated steatohepatitis, which is inflammation of the liver.
That's
Um,
MASH,
MASH, exactly.
formerly
Uh,
NASH.
yeah,
Yeah.
exactly. And a sub set of those patients, it's estimated about 10 to 15% roughly, will then go on to develop fibrosis and in some cases cirrhosis, which is permanent scarring of the liver. And at that point, that's irreversible, and that significantly increases one's risk of hepatocellular carcinoma, um, and also um, liver failure, and all the complications that arise as a result of that. So it's really crucial that we have this proactive approach.
Mm. Yeah, and intervene while we can, because I guess that all of this comes at quite a cost. And I suppose we think about, we tend to think quite short term and what's in front of us right now, which of course is completely understandable considering the volume that we see in primary care. But actually, I suppose prevention today can potentially save the whole health system huge amounts of money in the future.
Yeah, absolutely. I mean, I think I was doing a bit of reading recently, and there was a piece of work that looked at the potential economic impact of patients living with MASH on the UK health service, and it was estimated that it could be between 2 to 4 billion per year. So it's and I think, as you've said earlier, the difficulty is that's an estimation because we we haven't identified so many patients who are living with this condition.
I think the interesting thing there is that we're talking about, MASLD and its progression and the risk of cirrhosis and HCC and similar things like that and liver failure. But as far as I understand, the thing that tends to limit people's lives with this is not necessarily that, is it?
Absolutely. So, um, it is a risk factor for cardiovascular disease and a significant risk factor. So, we need to be really aware of that when we are managing these patients and look closely at um, the whole person, the whole patient, and think about those cardiovascular risk factors because, as you said, um, the likelihood is they won't progress to cirrhosis and it will be cardiovascular disease, which is the biggest risk of their overall health. an outcome long term. So thinking about their blood pressure, thinking about their HbA1c, thinking about weight management support if it's appropriate, looking at their lipid profile. These are all really um, key points, and I think we'll speak a bit about emerging medicines for this condition. But again, there's a huge crossover in the medications which we seem to be effective in patients living with MASH, and obviously we are now using already in patients who are living with type 2 diabetes, specifically.
Yeah, I mean, so we will tantalize our listeners. So we're going to talk about the newer medications, which I'm sure we've all been asked about towards the end of this podcast. But let's sort of wind it back. So we're talking about identification. We're talking about looking at the whole body approach. But something that we've probably all seen in the last week, the patient's blood tests. We're looking at them, and they've come back with deranged LFTs. So the AST or the ALT or both are raised. How would you recommend we approach that?
Really good question, and a challenging one, given that we see so many of these type of results. Um, I think the key point that I would say is, one, look at the history. Okay, so sometimes you might not have seen this patient, but you might be reviewing a blood test that's been done as part of their diabetic review, let's say, or their heart failure review. So really take a moment to look at their risk factors. Do they have risk factors for um, MASLD? Is there a history of alcohol excess? Because ultimately, these are still the most common causes of deranged liver function that we will see. Of course, as Hepatitis C Champion, I would say it's really important to think about their risk of bloodborne viruses. Um, and if you feel there is a risk, um, then consider this as an additional test. Okay. Um, of course, there are rarer causes of liver disease that we're taught about at medical school, things like Wilson's disease, alpha 1 antitrypsin deficiency, autoimmune hepatitis. Um, we aren't going to see many of these in primary care. Um, and of course, you have quite a detailed liver screen, again, that we're taught about. I would say personalize your approach to these blood tests. So, my key points when I look at these tests are: one, do they have risk factors for MASLD? Um, what's the trend of results? Have they previously had an abnormal liver function? What have we done about that at that stage? I think repeating a blood test is always helpful. And depending on how significant the derangement is, that will dictate how soon you repeat that blood test. But I think it's reasonable to think about maybe a 3-month interval, unless obviously LFTs are significantly deranged, and every area might have their own pathways and guides.
Yeah, so okay, so it's really helpful to know about the repeating tests because we'll often see them very slightly deranged, and as you mentioned, areas have different thresholds, different sort of pathways. So I definitely recommend people would look at locally. Certainly, look at their own local area. Certainly, locally, it's changed quite a lot of times over the previous few years. But I suppose I want to think about the next step. So I suppose we're the patient's worried about fibrosis, they're worried about cirrhosis or similar things like this. How would you suggest that we sort of go about reassuring them and reassuring us that they're not at that next stage?
Yeah, that's a really good question. And in recent times, we've got had the emergence of specific blood tests that, again, some areas will have access to and some won't. So specifically, there's one that most areas should have access to, which is called a FIB4 test. So it gives us an indication as to a patient's risk of fibrosis. And there are certain values in the guides online, which I'm sure we can share, that give us guidance on how we manage that result. So the cutoff in most areas is anything less than 1.3 on the FIB4 score is deemed very low risk of fibrosis, and actually the guidelines suggest these patients could be managed within primary care, of course, with those lifestyle advice and all of those things that we've discussed. If it's above that, then the guidelines suggest that these patients should have either what we call an ELF test, which again is a blood test that looks at specific biomarkers of fibrosis. And again, access to this will vary, or a FibroScan, which looks at the liver stiffness and the degree of hepatic steatosis. And then based on that, those patients will then be followed up in the appropriate way based on the results.
Oh yeah, fibroscans. Your fibroscans, it's interesting, and I think that can be really helpful. And certainly following that flow chart can be useful. I always find it an interesting thing because I understand that fibroscans were developed by utilizing the technology for aging cheese, which I think is quite a nice little way to remember that.
Yeah, fascinating.
Yeah. Okay, sure. So we've identified this, and hopefully they haven't got any particular fibrosis, but we've got these raised LFTs, and we think they might have uh, MASLD. Is there any other test that we might be thinking of doing?
So absolutely, I think it's really important to think about an ultrasound when you see these results. It's a very useful test, particularly when we're thinking about derangement of the LFTs. It's relatively easy to access in most areas, and it will give us an indication as to whether this patient does have MASLD or any evidence of um, cirrhosis. But predominantly, we'll be organizing this test to look at whether there is any fatty infiltration. Um, and then obviously from there, we can then think about the other tests that we've discussed.
Hmm. Yeah, I think that's helpful to know, and because essentially like working through that and thinking why we're doing things. So once we got these tests back, and we're sure it's not any of those other things we talked about, and so we suspect it's MASLD. What next?
So really key, um, I think, is to code it. I think that's key. I think historically, when our awareness of this condition wasn't as good as it is now, um, we perhaps didn't do that, and patients were having ultrasounds where this was diagnosed, and it was being filed without really much sort of action being taken. So I think that's key.
Yeah, we actually had a conversation about this in our practice this week, and about how important it is, especially for no other reason, to make sure that we're not rechecking them for the antibodies again in a few years' time.
Absolute, yeah, absolutely. So really key. Um, I then think it's really crucial, of course, to speak to the patient and provide them with um, advice with what they can do um, to reverse the changes that we've seen on ultrasound. And I think that's key, isn't it? With um, uh, the when you're speaking to patients regarding this condition, it's that positive messaging um, and health promotion because this is reversible. So, but also once you've done that, is again, as we said previously, thinking holistically. So, what is their blood pressure? You know, do they have a raised cholesterol? Is their HbA1c poorly controlled? Bringing in your allied healthcare professionals, do they need a diabetic review? And this is how we should be managing these patients. Hopefully, in some areas, there were well-established pathways for dietetics and weight management. We know that that's not the case always, but again, thinking about that is key. Uh, yeah,
It's coming back to this whole body, whole person assessment that I think needs to be at the core of what we're doing. But as I learn more in this kind of metabolic space, if you like, and we're stopping even talking about cardiology and renal, we're talking about CRM, cardio, renal, metabolic, and of course liver disease here. Which it's about thinking about the patient as a whole and thinking about how all of these things interplay. That's what's really coming home to me.
absolutely, absolutely. It's the evidence is clear that there is a strong link between all of these conditions, and we need to be treating them as one with input from our colleagues in secondary care, colleagues in the community as well. Diabetic specialists, nurses, and the community diabetic teams, your renal teams, your um, cardiology as well. Again, a lot of these patients may well have heart failure or ischemic heart disease. So it's really, really crucial. And I guess, um, again, it lines with the long-term vision for the NHS, to bring care into the community. How that looks, um, who knows? But I think liver disease fits is
Mm,
such a key part
mm.
of that, to be
Yeah,
honest.
and so often overlooked. I mean, it was interesting when you were talking about sort of secondary and primary care interactions with this. And I was actually thinking that for a lot of this, because it's preventative medicine, it firmly sits in primary care. That's likely where it is, and of course with the longer term plan. Um, yeah, and so I think I'm really glad that we've been able to talk about it today. Talking about sort of longer term and thoughts for the future, we did promise people we were going to talk about some of the emerging treatments for this. So, of course, mainly lifestyle, mainly exercise, diet, improving lots of those other things from the whole person perspective. But what's on the horizon? What might we see over the coming years?
So um, there is definitely a body of evidence to support some medications in the treatment of patients with MASH. Specifically, there is some evidence for vitamin E and pioglitazone, but probably more relevant to listeners are the GLP, GIP, and agonists. So specifically tirzepatide, which I'm sure we've all had uh, lots
Lots of
of
letters
requests.
about.
Yeah, lots of letters, lots of requests for. But actually, there was a recent trial that was done, published in the New England Journal of Medicine, in patients with MASH and fibrosis who were given randomized, double-blind, randomized control trial looking at the role of tirzepatide versus placebo. And what they found was patients randomized to the treatment group showed significant improvement in MASH with resolution of MASH compared to the placebo group. So really, really encouraging, and again speaks to the point that we've just been discussing about that cardiometabolic renal liver syndrome, that these medicines are so effective, or appear to be so effective in improving outcomes in these conditions. And it's I'm sure that in over the next 5 to 10 years we will be prescribing these, hopefully more easily to the patients who need them. um, but yeah, so it's definitely an evolving space, um, but lots of really encouraging evidence out there.
Yeah, I mean, and that's good to hear. And you know, it sort of makes sense, doesn't it? Like a lot of this is to do with um, obesity. A lot of this is to do with the overall health of patients, and I think that there are some very interesting things on the horizon in this space. And so, yeah, it's great to hear that there's this investigation going on. So, I mean, we've talked about a lot today. We've talked about, I think, hopefully, we've made a very good case for why GPs should be interested in hepatology and gastroenterology. Before we finish today, so as I said, we've talked about a lot of things. If you were to give us one message to change our practice that could make a real difference for us and our patients, what would that be?
Great question. The take-home message is, um, MASLD is extremely common. One third of the population estimated to have it. We could do a huge amount to reverse it in primary care.
And that's a wonderful thing for us to finish on today. Thank you so much, Dr. Fijten. It's been really, really interesting. I think people have learned loads from this. And thank you everybody for listening at home. We hope you have found this interesting and stimulating, and look forward to you tuning in on the next GP Notebook podcast, which are available every week. Thank you very much. We'll see you next time.